I'm an emergency medicine physician at University of Missouri, Columbia. The bulk of these slides were made by Dr. Abdulli Najai, who's one of our orthopedics residents and who's originally from the Gambia. Unfortunately, Dr. Najai was emergently called into work for reasons I can't discuss here, but he will have to work today and won't be here with us, which is sad and unfortunate. I'm hoping he'll be able to join us at a future date. And then I will let Dr. Nick Maxwell introduce himself as well.
Hi, I'm Nick. I did emergency medicine residency at Washington, St. Louis, and now I'm a medical education and simulation fellow at Hennepin County in Minneapolis. And will also be the spreader of the word that Jess said, PowerPoint is better than Google Slides. So
Thanks, Nick.
that'll be my contribution.
And I know I've met Fatumata. Benjamin, I'm not sure if we've met before, but I'm the medical director for Techies Without Borders. And Nick and I have been co-running this journal club together for about a year and a half. And the recording will be posted on YouTube, and we will also share a summary of our slides and of what we talked about during the session in our WhatsApp groups. And if there's any friends that you think would like to join the session, please do send them a little message in WhatsApp and encourage them to join in anytime. It's okay if they come in late. And with that, we'll get started. So our agenda is to go through an introduction and then some cases, and we'll talk about pediatric orthopedic infections, specifically septic arthritis and osteomyelitis, and then we'll do a wrap up.
Somebody just tried to join, and I thought I clicked accept, and it didn't join them.
Oh,
you see one hiding?
There's more people trying to come in. Let me make you host. Maybe that'll help.
Ooh.
Make host.
Don't worry, even with that power, I will still allow others to screen share.
Oh, can you, give me the screen sharing ability. Sorry, guys. 1 second. Technology issues, which never seem to get better despite how long we've been using Zoom at this point.
I got the power.
Okay. Let's see. Sorry, hold on 1 second. It won't let me see my presenter slides now. Can you? Sorry, guys. All right, are you guys seeing a presentation or presenter view, Nick?
I see presentation.
Okay, perfect. All right. So at this point, what is CMES Journal Club? Why are we here? So CMES stands for Continuing Medical Education Solutions, and we are essentially a program run by the parent nonprofit Techies Without Borders. Our goal is to deliver free continuing medical education in limited resource settings. And for those of you who have a CMES device at your institution, we basically use tiny computers that project an intranet signal so that you can get offline access to free education on your phones or your computers. CMES Journal Club is designed to foster ongoing engagement with the program and get people excited about reading more on our devices and using our apps. All of the topics that we discuss at these sessions are topics that are contained within the CMES library on your app. So I'd encourage you to go read more on your own time after the session. So let's start off with some cases. We have a 6-year-old boy from Serekunda in the Gambia, brought in by his mom to the outpatient clinic with a complaint of a limp for 2 days. He's had a mild flu-like illness with cough and runny nose for about a week. It started a week ago. And then the family first consulted a traditional healer who applied some herbal rubs to the thigh, but he's not getting any better. What's on your differential diagnosis at this time? And you can feel free to speak out loud or chime in the chat with what you think might be on your differential for this 6-year-old boy with a limp who just had a viral infection 1 week ago.
And also, as always, feel free to speak up too if chat's hard. For example, if you're on your phone and it might be hard to switch back and forth, we're always happy to have you speak up.
Yeah. Nice. Osteomyelitis. Thanks, Rebecca. What other things are on people's differentials for hip pain, limp, had a viral illness a week ago? Septic arthritis. Awesome. Thank you, Fatimata. How about more benign causes of a limp in a kid who just had a viral infection? JD, what's on your differential? Yeah, okay, awesome. A bunch of people just wrote in. Ruth and Fatimata both said transient synovitis. Wonderful job. And we'll get to what that is in a couple minutes. So this child is well appearing, so that's a good sign. He's afebrile and he's holding his hip in a position of flexion, abduction, and external rotation. When you passively internally rotate his hip, he has pain, but there's no swelling, warmth, or erythema around the joint. So those are all good signs. Pretty encouraging. You do get some labs because septic arthritis is on your differential diagnosis at this point, and the white blood cell count is normal. The inflammatory markers are also normal, and you've got a reassuring x-ray, though x-ray is not super helpful for diagnosing septic arthritis. And there is a joint effusion on ultrasound. So what is your final diagnosis at this point?
Hello.
Hey, we can hear you. What's your
Wow.
final diagnosis? Awesome. Thanks,
Okay.
Fatimata. Transient synovitis. Great job. So this
Sorry,
is
also.
usually,
I'll not back right tomorrow.
Nick, would you mind just muting folks if they're not actively answering questions for me?
Next week.
Yep.
Next
Thank you.
month.
Working on it. It's not muting. There
Thanks.
you go. Got it.
Okay. So transient synovitis typically presents with an acute onset of limp and a mild hip pain. And the classic thing is that people will have a viral infection, usually within a week before that. These kids should be afebrile, but not always true. I have seen transient synovitis with fever. And then in terms of systemic symptoms, they might have viral infection symptoms if that's still lingering on. A limp is the classic finding. And then what's really key here is that the patient may have limited range of motion, but there shouldn't be any erythema or warmth. Those things would be more concerning for septic arthritis. Lab studies are usually normal, and if the white count is elevated, we would expect more of a viral pattern, meaning more of a lymphocytic predominance instead of neutrophilia. ESR and CRP are typically normal. They might be a little bit bumped, but they shouldn't be wildly high. And then you may see a joint effusion on ultrasound. This is a clinical diagnosis. However, if you're really unsure if this is a case where you're sort of on the fence, could this be septic arthritis, meaning they have slightly higher white blood cell count and inflammatory markers, they're actively febrile, maybe there is erythema or warmth, then we really should be getting a joint arthrocentesis to exclude septic arthritis before we conclude that this is a transient synovitis. Transient synovitis is managed with NSAIDs, rest, and observation, and then the typically will get better in 1 to 2 weeks. I do want to mention one of our senior residents from University of Missouri Columbia is here, and he's planning on doing a pediatric emergency medicine fellowship. And so if you have anything that you want to chime in, either in the chat or out loud throughout the presentation, JD, because peds is your area of specialization, please feel free to do so. All right, moving on. So transient synovitis refers to an inflammation of the synovium of the joint, and it's a very common cause of hip pain in kids. Again, septic arthritis is our biggest differential, and I appreciated, I think, that Ruth had osteomyelitis on her differential too, because that is theoretically possible. It is the most common cause of hip pain in pediatric patients, and unfortunately, it might recur. So if you've had it once, you can have it again in about 1/5 of cases. Most of the time this is happening in boys. I don't exactly know why. I would have to go do a deeper dive on why boys are more often likely to get this, but the same thing applies to osteomyelitis and septic arthritis. So we're typically talking about young boys. This can affect any major joint, but we do typically see it in hips. And the exact cause is thought to be an inflammatory reaction in response to whatever underlying thing a kid had. So if they have an upper respiratory infection, they just get a little too much inflammation going on, and then they get some joint inflammation. Like we said, this is a self-limiting disease. And mild fever can happen. You can have acute or subacute onset of hip pain. They may refuse to bear weight, and that can improve throughout the day, which, as many of you know, is kind of a classic finding for inflammatory things. So rheumatoid arthritis, other joint arthritides, some of those things will be the worst in the morning and get better as you use the joint. It's almost like you're moving around all of that inflammation, and it sort of helps reduce the pain and symptoms as the day goes on. There might be associated muscle spasm. And then putting the leg in flexion, abduction, and external rotation can help the kids' pain if they're not already doing this on their own. A really key point is that this person should not look toxic. They shouldn't look really sick. Yeah, they might have upper respiratory infection symptoms, but they shouldn't look like septic. And if they do, then you should be more worried about septic arthritis. We already talked a bit about the workup, so I won't dive into all of these things, but MRI can be helpful if you're concerned for concomitant osteomyelitis, or you think they might have a pyomyositis, like an abscess or an infection in the surrounding muscles. So if they have spasm or tenderness in the surrounding musculature that seems out of proportion to just the transient synovitis, you may want to consider more imaging. Okay, and we already talked about the treatment, which is supportive care. Feel free to chime in with any questions about transient synovitis in the chat if you have them, but we're gonna move on to case 2. So we've got a 3-year-old boy who's coming from a rural village in the northern area of the Gambia. He's brought to the tertiary care hospital, Edward Francis, by his father after 3 days of fever, refusal to bear weight, and severe hip pain. The family initially thought it was due to the evil eye, and they sought treatment from a marabout. And after worsening symptoms and persistent high fevers, his dad arranged to take him to the hospital. What features about this case make you more nervous about septic arthritis compared to case 1? Feel free to speak out loud or chime in the chat. What is a red flag with this case? What are we worried about? I know Fatumata and Ruth have been very active in the chat. I'd love to see some other people chime in too.
What makes me nervous is more the high fevers going on for multiple days and then the coincidence of refusing to bear weight.
Yeah, good. And Rebecca said concern for sepsis. I totally agree. And Sidwell also said failure to bear weight. Great job, guys. So this kid sounds sick, right? He sounds much worse than the kid in case 1. So moving to his physical exam, he looks toxic. So he looks bad and he's febrile to 39. Remember, you can have mildly elevated temperature and transient synovitis, but we shouldn't see high fevers like 39 degrees Celsius in a kid with transient synovitis. He's holding his knee in the same position as a kid with transient synovitis because that's going to be more comfortable. The flexion, abduction, and internal rotation, or sorry, external rotation. And with the other kid, we were able to do some passive range of motion, but it hurt. For this kid, you really can't do any passive range of motion because it's so painful and uncomfortable. And he's got marked tenderness over his hip joint. So we've got a lot of red flags on this physical exam that are more worrisome for septic arthritis. And unlike the first kid, this one has elevated inflammatory markers. He has leukocytosis. And just like the transient synovitis, he has a joint effusion. And what procedure do you think you would perform at this point to help you figure out what the diagnosis is? What should be done for this kid to determine if he has septic arthritis?
I think we should tap it.
I agree, Nick. I think we need to tap this joint. So this kid needs an arthrocentesis. And this can be really challenging, right? It's not a comfortable procedure. The hip joint is a pretty hard joint to get a needle into. I'll be honest, in my setting, we often do this sedated or in the operating room. It's rare that we're doing an emergency department hip arthrocentesis for a child, just because it's a very hard joint to access. And this doesn't look like a very large effusion. The smaller the child, the harder it is to access that effusion. I would love to hear in the chat how most people are approaching arthrocentesis in a child, especially someone small, in their settings. And while we see those responses in the chat, we're going to move and talk about the Coker criteria. So the Coker criteria help you determine the potential risk for a pediatric septic joint. And the more of these you have, the higher the probability of having septic arthritis. So non-weight bearing, you all mentioned that in the chat. Great job to those who said that was a red flag to you. Elevated ESR more than 40, a fever, and leukocytosis more than 12,000. If you have 4 out of 4 of those criteria, you should be very worried. And then if we go back here, this kid does get a joint arthrocentesis, and the fluid is turbid, meaning it's full of leukocytes. And he's got a markedly elevated white blood cell count of 54,000 in that joint fluid on aspiration. It also has a left shift, 98% neutrophils, which highly suggests a bacterial infection. I do want to note we're not going to get into the more, I guess, strange types of septic arthritis that you can have, like tuberculosis, or some of the more benign organisms that may not have these classic findings on joint aspiration today. But I would encourage you, if you're worried about a tuberculosis septic arthritis, to make sure that you do some reading and homework on how that fluid would look different. JD says he's seen hip arthrocentesis done using ultrasound, but yeah, IV sedation was used. And same in my experience, I've never seen a kid be able to tolerate a hip joint arthrocentesis awake. I have done a knee awake for a very stoic child who was able to tolerate just local anesthesia, but a hip is hard because it's closer to the trunk. So you're going to get this kid really nervous if you're jabbing needles somewhere fairly close to their belly. And then the younger they are, the less likely they are going to be to sort of follow your instructions to lay still and not move around. So this is a tough joint to access. Okay, so septic arthritis of the hip. We've already mentioned a lot of these things, but the classic findings are swelling, warmth, erythema, tenderness, and severe limitation of movement with refusal to bear weight. You should see a large effusion. I don't think I would call the effusion we saw on this ultrasound large, but if there's any effusion, then you need to consider going for it with a hip arthrocentesis if this is on your differential. And then definitive diagnosis does require a sample, right? And ultimately, any case of septic arthritis needs not only antibiotics, but they also need surgical drainage. And we're going to dive a little bit more into that in a few minutes here. But essentially, we always start out with IV or intravenous antibiotics and then move to oral therapy when someone's clinically improving. We need to make sure that those medications are targeted to whatever bug grows out on culture. And there are sometimes cases where nothing grows, but we have a strong suspicion for septic arthritis. And those are cases where orthopedists will select empiric antibiotic therapy based on what's common in their area. So this is a surgical emergency, and about 50% of cases in children happen under the age of 2. So a kid is not necessarily going to be able to tell you when they're less than 2 years old, ow, my hip hurts. So refusal to walk is a big red flag, especially associated with fever. Hip and knee are equally common in terms of presentation of septic arthritis. And then risk factors are obviously going to be anything that immunocompromises you or that leads to compromise of your skin barrier that prevents bacteria from coming in from the outside. So if you're premature, you spend time in the neonatal ICU. If you're born via C-section, there's more risk. And then things like having an umbilical catheter or heel sticks during your infancy. Inoculation routes can happen many different ways. And we'll talk about this again multiple times, but hematogenous, meaning blood-borne seeding of a joint, is actually more common in children than it is in adults, whether it's osteomyelitis or septic arthritis. And so if the person looks ill, we really need to be getting blood cultures. And then remember that if you have bacteremia for some reason or another, you can end up seeding multiple joints. Certainly, we're not going to be, hopefully, seeing intravenous drug use in little children, but I've seen in adults many cases of intravenous drug users who have septic arthritis in multiple joints because of hematogenous seeding. So just keep in mind, if you have bacteremia, it's not impossible to get septic arthritis in more than one joint. So septic arthritis leads to destruction of the cartilage and can therefore cause chronic pain, disability, arthritis, immobility. So this is going to be a lifelong burden for the family if it's not diagnosed and treated early. And articular damage can happen as early as 8 hours. So it's really important that we get on top of this early in terms of our recognition and management. I wanted you to take a look at the bugs in this table that Abduli included. I think this is really important to note that a neonate, group B strep, is going to be the most common cause, which makes sense, right? Because group B strep, listeria, those sorts of things are the bugs we typically expect in a neonate because they come from the vaginal flora. So group B strep, especially if mom did not receive antibiotic prophylaxis at the time of delivery, is going to be an issue in neonates. For children overall, Staph aureus is the most common in kids, particularly over the age of 2, and it's going to be the same thing in adults. And then Neisseria gonorrhea is most common in adolescents, so we should be asking about sexual history and risk factors. So if they've been having unprotected sex, they're certainly at risk for this. Group A hemolytic strep is common after varicella infection. So if you're in a setting where chickenpox is still common, you should definitely have that on your differential. And then keep in mind things like HACEC organisms. This table actually does not include Kingella, but I was reading some updated guidelines and recommendations, and it turns out that Kingella is one of the most common causes of septic arthritis and osteomyelitis in kids less than 5. And unfortunately, that one doesn't always come back positive on blood cultures or on joint cultures because it's one of these HACEC organisms that are really difficult to grow. So keep Kingella on your differential. Another thing that came up in one of the articles I sent out to you guys is that kids who have Kingella, so like babies usually are the ones presenting with this, don't often have as high of white blood cell counts, ESR, or CRP, meaning that the Coker criteria are not going to be super helpful for you, right? So if septic arthritis is on your differential, it's always better to go ahead and get the joint aspiration if that's something that's available in your setting. Okay, then moving to some other bugs. This slide is more for your reference to go back to later. We always send these slides out, but Dr. Najai wanted you to remember that some of these bugs will require special media. They're not just going to grow on normal aerobic and anaerobic cultures. So Kingella that we just mentioned, which is very common in children less than 5, needs blood culture medium, even to grow from a joint aspirate. And then Mycobacterium TB, if that's common in your setting, which I know it is for a lot of you, Lowenstein-Jensen media. I will say from what I was reading, TB, septic arthritis, and osteomyelitis are not terribly common in immunocompetent patients, but they are still a thing that can happen. I actually recently heard about a case of an adult who had isolated septic arthritis from TB and had no other systemic manifestations, and they were not immunocompromised. So still needs to be on the differential. And if TB is common in your setting, I would go ahead and make sure that you get a specific culture for that from the joint aspirate as well as the blood cultures. Mycobacterium avium, not as common a cause of septic arthritis, but here's the medium you would need to use. Neisseria for your teenagers with risk factors, I would use the Thayer-Martin media. And then E. coli, not a very common cause of septic arthritis, but you certainly can have gram negatives, especially in, let's say, a child who was in the neonatal ICU. They had E. coli bacteremia, things like that. You really need to think about it. So prognosis is worse for kids less than 6. And maybe that's because of delayed presentations. I would have to go do a little bit more digging and looking, but the younger you are, the less likely you are going to come up and say to your parent, hello, my hip hurts really bad and I don't feel well, right? So it's just going to present as a limp. And if parents are busy working, they may not notice that limp until you have pretty significant damage to the joint capsule. And then delayed diagnosis over 4 days also has a worse prognosis. And unfortunately, those kids are more likely to present sicker at that point. One thing I want to mention is that prognosis is definitely worse if you have a hematogenous case of septic arthritis, because again, those bacteria can go wherever they want. If they've been in your bloodstream, they can go to other places as well. Oh, JD just mentioned in the chat, and I appreciate this, for individuals with sickle cell disease, salmonella and encapsulated bacteria are the most common cause. And yes, that is super important. And we do include that in the guidelines at the end of this presentation. We go through the Gambian and Ugandan guidelines, and they have very specific stuff for folks with sickle cell. So thank you, JD, for mentioning that. We've already talked a bit about the difference in presentation from transient synovitis, but a key thing to remember is that if you have septic arthritis, you can spread to adjacent areas. So you should be palpating other bones around the site of pain. So you should also be checking for, is there pain in their back, pushing on the vertebrae? Is there pain in the other hip and surrounding joints like the knee? And then in a neonate, you should be ultrasounding both hips if you have a septic joint, because babies have a weaker immune system than the rest of us. So make sure they don't have effusions on both sides that would make you think, oh shoot, they have hematogenous seeding of both joints. We've already talked a bit about the Coker criteria and covered most of these things. But key point here is that you need surgery. All right, so Dr. Najai wanted me to emphasize that cultures before antibiotics are critical. But the exception, I would say, to needing joint cultures before antibiotics is, like we've said, it's really hard to get an aspirate or an arthrocentesis from a small person's hip joint, especially a very tiny person. They're often going to need sedation. And if someone is coming in with sepsis and particularly septic shock, we should not be waiting to give antibiotics, like broad spectrum antibiotics, before tapping that hip. I would say try to always get your blood cultures before antibiotics if possible. But if someone has impossible IV access, let's say they've been in septic shock at home for a couple of days, they're very dry, dehydrated, they haven't been eating, it's pretty hard to get peripheral blood cultures. So considering things like, do I need to put in an intraosseous line, an IO, in a non-affected limb? Make sure you're not sticking things like needles into the limb that you're concerned about, right? So do I need to put an IO into this kid's other tibia on the other side to get those blood cultures and then give antibiotics through that? If you can't get IV access, giving through IO or intramuscular, those are still parenteral routes of antibiotic administration. So just want to emphasize this, Pearl, that you should always get blood cultures before antibiotics if possible. And you should always go ahead and give empiric antibiotics if your child is septic, and especially in septic shock. And in other cases where someone does not appear terribly, terribly ill, it's okay to wait and get the culture from the joint before you start antibiotics. I know I'm beating this point to death, but I just want to make sure everyone knows that this is an emergency if they are presenting septic. So I just want to highlight here that these are international pediatric infectious disease guidelines, and they're saying that kids who are ill appearing or have rapidly progressive infection, meaning they're systemically ill, they need to get empiric antimicrobial therapy before they get their joint tapped. So this is not just me saying this, it is supported by international guidelines. Another key point is that septic arthritis is usually hematogenous in kids. So please, please, please get blood cultures in addition to an arthrocentesis. And this is, again, supported by international guidelines. It's not just a me thing. And then finally, the Coker criteria have major limitations. They were developed before MRI, so they can't help you detect, especially if there's cases of adjacent spread of infection. If there's osteomyelitis adjacent to the septic arthritis, or if the kid has now developed things like pyomyositis or abscesses around the site of septic arthritis, the Coker criteria are not going to help you. So they're not the be all end all. And I just want to emphasize here that once it's been more than 4 days since the onset of symptoms, the likelihood of spread of that septic arthritis to surrounding areas, so to adjacent bone or to adjacent muscle, goes up and up and up. So the Coker criteria kind of go out the window in those situations.
Hey, Jess, all right. Yeah. Question, I think for the group is how many blood cultures do you get in kids? I know generically in adults, a lot of times they'll do 2, and kids sometimes they'll do 1. Does that change if you're worried about a septic hip?
Yeah, great question. I would always prefer more than less when it comes to blood cultures. I am not a pediatric emergency medicine physician, but I treat both kids and adults. So my specialty is not within only peds. I see everybody. I would say most of the time, 1 set of blood cultures is okay for a child. But if you are strongly suspecting that this is going to be a weirder bug like Kingella, because this is a baby or like a really tiny child, it's better to get 2 sets if you can, just because those are difficult to grow. Same thing goes for, like, if you think it's going to be tuberculosis based on their history and risk factors, it might be better to get 2 sets of blood cultures, because not only is that going to increase the likelihood of a true positive, but you'll also have more blood available to send for all these various culture media for the weirder bugs. I hope that kind of makes sense. But I think for an older child who is less septic-y looking, or for someone who's really not septic appearing, it's probably fine to get 1 set of blood cultures. Okay. 12-year-old boy coming in to the large tertiary care hospital for 1 week of fever, severe pain, and swelling in his left ankle. The family initially thought the pain was due to just growing bones, and they gave him paracetamol from the local pharmacy. But then he developed a fever and loss of appetite, so they traveled overnight to the main hospital. What's on your differential diagnosis for this kid? More of a subacute presentation than with some of these other cases, especially the septic arthritis that we talked about. I'll give you a hint. This is what his ankle looks like. Thank you, JD. Yeah, osteomyelitis is certainly on my differential. And then if he's refusing to move his ankle joint, then I'd be worried about septic arthritis as well. But we'll say in this case that he can move his ankle joint, and he has focal tenderness overlying his distal fibula. And he's got pretty severe pain with palpation there. You guys can see from this picture that his ankle is very red and swollen, and it would be warm to touch if you palpated it. Yeah, thank you, Ibrahim. So cellulitis. One thing that makes me more nervous that there's something deeper going on than just cellulitis here is that he does have focal bony tenderness. But just from looking at the picture, I 100% agree with you that cellulitis or even like a superficial abscess are on the differential. So this kid has pretty bad leukocytosis and very high inflammatory markers. And you can certainly see those findings with just cellulitis or just a superficial abscess. But unfortunately, his x-ray also shows soft tissue edema, and he's got periosteal bone formation at the distal fibula. So any further workup that you would want to get at your institution? This kid looks like he's got some periosteal issue with the bone. What imaging would you consider getting next where you work? Feel free to chime in out loud or in the chat.
I'm very lucky to have an MRI available, and that's typically what I would go for.
Yeah, I agree with you, JD. So MRI would be the best choice here if it's available. It is the preferred imaging modality, especially for children, because there's no radiation involved, but also because it has better sensitivity and specificity for identifying osteomyelitis early in the course of infection. It can even pick up on marrow edema, like in the very, very early stages of osteomyelitis before you see anything on CT or on X-ray. And then Gina said she would normally get a bone scan in her setting, which I think is also a great choice if you don't have MRI. And yes, I agree with biopsy too, right? So with osteomyelitis, this one I think is less likely, at least in my experience, to be associated with florid sepsis unless it is, again, coming from a hematogenous source. And sometimes with these more subacute cases, the patient is not floridly ill. But if they are septic, once again, I would go ahead and get the blood cultures and start the antibiotics before you obtain an actual bone biopsy sample, because it's kind of hard to get a bone biopsy. You have to be somewhere that you have an orthopedic surgeon and can go to the operating room. But if they are not septic, then they definitely need to get a biopsy before you give empiric antibiotics, because you can accidentally cause false negative cultures when they go in for surgery. And just note in this picture, the x-ray is not super obvious yet, but there is some breakdown of the bone right along the growth plate here. And apparently there is some adjacent edema, which I'm not really appreciating in this image, where the big arrow sign is. It's hard to see on this screen. Maybe it's better on the radiologist screen. Yeah, Nick, I don't really see it. But it's very obvious on MRI that you guys can see breakdown of the periosteum, which again is the layer on the outside of the bone. And there's a soft tissue defect here, which we're not really seeing on the x-ray. Apparently there is one. So this person must have had a pretty bad wound first too. Now, what if you don't have any advanced imaging? I did want to put a plug out here for this because I just did point of care ultrasound training with many of you in the Gambia like last week. So you can sometimes pick up on findings of osteomyelitis using bedside ultrasound. And this is not like a guideline recommended thing yet, so please don't opt for doing ultrasound. But I just want to encourage those of you who are savvy and able to use POCUS that if you are concerned about osteomyelitis and you're trying to decide, do I need to ship this kid somewhere else to get an MRI because I don't have it in my setting, or I don't have an orthopedic surgeon, it could help you with making your decision. So this case report that I found, when compared to the rib on the other side, this child who was febrile and had focal bony tenderness actually had some periosteal edema, and then increased color Doppler flow to the musculature surrounding that rib that would suggest, okay, there's a lot of blood flow going there because there's probably an infection or some kind of inflammation. And then there are some case reports out there of even periosteal breakdown or like defects in the periosteum of the bone that you can pick up on ultrasound. Realize many of you saw last week when we looked at bone on ultrasound that there's posterior shadowing with bone, meaning so you can see the periosteum and then everything behind it is black. So you're not going to be able to see the marrow of the bone well with ultrasound. So that's a big limitation, but you can at least see if there is edema and breakdown of the periosteum. All right, so we kind of talked about this already. Moving on, so acute osteomyelitis usually presents with subacute onset of bone pain, a fever, and a limp. And I want to emphasize that in kids, hematogenous causes of osteomyelitis are more common than in adults, but you have to go with what's going on with the patient, right? So if this child in the case presented saying, oh, I cut my ankle last week and now I have these findings, that would make you more suspicious that this is local spread from trauma as opposed to a bacteremia. As we mentioned with septic arthritis, boys are more likely to get this, and the literature suspects that this is because boys are more physically active and more likely to be constantly cutting themselves, like small micro trauma from playing outside and running around and things like that. And so those little micro abrasions to the skin can lead to entry of bacteria and then hematogenous seeding. Labs in osteomyelitis should show leukocytosis and elevated inflammatory markers. And we already said that X-ray is really kind of terrible for identifying osteomyelitis until it is advanced. So you cannot rule out osteomyelitis based on your X-rays. And then again, I would wait on IV antibiotics unless this child is septic, because you really do need a bone aspiration or biopsy to confirm what bug is causing the problem. And these people are going to need longer durations of antibiotics even compared to septic arthritis. So there's a lot of literature now for septic arthritis that you can start with IV antibiotics and then move to oral antibiotics once their CRP has dropped to a normal level and they're clinically improving. But for osteomyelitis, it's often going to be a long duration of antibiotics, and your orthopedic surgeon will have to determine when it's appropriate to switch from IV to oral agents, making sure that they're antibiotics that really penetrate bone well. And again, surgical debridement is going to be a staple of management here, just like with septic arthritis. You need to get that infected tissue out so that it doesn't get worse. We've already kind of mentioned all of these things, but there are cases that will be non-operative in terms of treating osteomyelitis. So if there's no associated abscess, they might be able to get away with not actually scraping away bony material, but they are still going to need a bone biopsy. So this requires and involves a surgeon. This isn't something we can manage just plain medically by ourselves if we are not surgeons. All right. Oh, one thing that Abduli mentions here too on the slide, MRI is helpful, particularly if you have it because it can identify surrounding infection. So if you actually have spread of infection into surrounding muscles and things like that, MRI will be better at picking those up. I was reading some of the articles I sent out to you guys say that universal MRI doesn't make sense. And I would agree, especially if you're in a limited resource setting where MRI is, a precious resource and you may not even have access to it at all. You obviously are not going to be able to do universal MRIs. But if you have any suspicion for a surrounding abscess and you're not able to pick it up with your other imaging modalities, then you might want to consider an MRI where available. JD just mentioned in the chat that children with osteomyelitis will usually have it at the metaphysis because of the localized increased blood flow. That's a great point. Thank you, JD. So because again, hematogenous spread is the most common cause, places of the bone that get a lot of blood flow are going to be where you have osteomyelitis showing up. And then he also said, because those areas have more cartilage, it's one of the reasons that x-rays have lower sensitivity for osteo in children than adults. Yeah, so kids are less ossified in their bones than adults. There's a lot more cartilage. And so if you are particularly infecting an area that has more cartilage, you're simply not going to pick it up on x-ray. Great points. Thank you. We've already mentioned that boys are more likely to get this. Osteomyelitis is not incredibly common, but 1 in 5,000 children younger than 13. Mean age is 6.5 years. And then, like JD just said, rich metaphyseal blood flow and an immature immune system are things that put kids more at risk for this than the rest of the population. And I just want to emphasize here, you do not need to be immunocompromised to get osteomyelitis as a child. Like we said, you might be a 5-year-old boy running around playing with your friends outside. You get a tiny cut in your skin and some bacteremia develops, and then you can see these blood flow rich areas of your bone. Risk factors, however, are going to be things that compromise your immune system. So if you have any of these things going on, and then a history of trauma is reported in 30% of patients, but remember that most little kids run around all the time, and so they may not recall any specific trauma. Even just a tiny cut can be your source for infection. So the most common organism is going to be Staph aureus in pediatric osteomyelitis. And then strains of MRSA and PVL, which is another drug-resistant bug, are now being community acquired. From what I've read, that's more common in the United States than in most of your settings. But if you know that you have community-acquired MRSA, you may end up having to provide this child with antibiotics that cover for that, especially if they are septic when you see them in the emergency setting. Kids who get PVL positive strains of staph are more likely to have complex infections and complications. So if you do end up seeing that one on culture, be a little more nervous that this kid has a long course ahead of them. And then kids who have MRSA are more likely to have DVT and septic emboli. So MRSA is just a really aggressive organism, and they're going to be higher risk for worse outcomes. Other bugs to consider for osteo. I know JD already mentioned salmonella in kiddos who have sickle cell disease. Other encapsulated bacteria, sickle cell, you need to think about that. And then for little babies, somebody who is just vaginally delivered, group B strep is going to be higher on your list. That HASEC organism, Kingella, comes up again. And that's one that's kind of hard to grow on cultures. So making sure, again, that you get blood cultures for these kids in addition to getting the bone biopsy or bone cultures. I have not seen a Pseudomonas osteomyelitis, but if you're dealing with someone who's chronically in the hospital, especially if they've had Pseudomonas before, it's better to cover for that if they're coming in toxic or sick. And then H flu is less and less common now that most people are getting vaccinated. But if you are working with a low vaccination rate population, like in some states in the US now, anti-vaxxers are getting so prevalent that we're seeing tons of measles and things like that. So in those populations where they're just not doing childhood vaccines, you may have to keep H flu higher on your differential. And then tuberculosis is more common in immunocompromised populations. But in the chat, I would love if people could chime in on how often they see tuberculosis osteomyelitis, because that's not common in our setting. But I'm guessing, given that tuberculosis is more common in general in a lot of the places you guys work, you probably see this more often than we do. And then keep in mind for immunocompromised people, you can get fungal osteomyelitis, which is really gross. So in your HIV patients who are not on or not compliant with antiretroviral medications for one reason or another, you can see things like cryptococcus, histoplasmosis. So fungi can cause osteo too, which is pretty gross. All right, so moving on, we already kind of mentioned these things, and you'll have access to these slides. TB, remember that you can have extrapulmonary involvement. Okay, and then one pearl I want to emphasize is that septic arthritis and osteomyelitis are a spectrum. You can have both at the same time. So delayed presentation of septic arthritis, you're more likely to have already spread to adjacent bone. If you have hematogenous seeding of whatever bacteria, you can have both of these things at the same time. So one does not exclude the other. So I'm glad a lot of you had both on your differentials earlier. Let's go over some guidelines in terms of what we should be covering people with for septic arthritis first, and then we'll move on to osteomyelitis. So these are international guidelines on the management of septic arthritis. The guidelines all say that if someone is really sick looking, you need to go ahead and give empiric antimicrobials before you get the culture of whatever bone is infected or joint is infected. And if this person is like a normal human who's not immunocompromised, doesn't have sickle cell, nothing else crazy going on, so no wild risk factors, then you should probably be giving a semi-synthetic penicillin, so something like cloxacillin or cefazolin, plus ceftriaxone, or just giving amoxicillin clavulanic acid, because that will cover all the things you need to cover. And then when can you switch over from IV to oral for septic arthritis? So usually we need to give IV for at least 1 to 2 weeks. And then once the person is clinically improving, their CRP comes down, their white count comes down, so they look better overall, then you need to switch to a really good at penetrating bone and joint oral antibiotic, and make sure that you're targeting that oral antibiotic to whatever organism they grew on cultures if they did grow something. We're going to go through the Gambian clinical guidelines. So if you are at an outlying facility that doesn't have the capacity to drain the joint yourself or tap the joint yourself, they actually recommend starting IV antibiotics stat for septic arthritis, even whether or not they're toxic or septic. I would love to hear from someone practicing in the Gambia, whether that's usually the practice where you work. I hadn't seen that before, like just giving empiric antibiotics, whether or not they're septic. Because certainly antibiotics are not benign, right? Gentamicin can have ototoxicity, it can have renal toxicity, so there can be problems with that. So I am interested to know if people are giving empiric antibiotics even before a joint tap, and even if the kid does not look sick. And then the guidelines for in-hospital, like at a tertiary care setting, definitive management. For adults, they're actually recommending oral antibiotics rather than IV. So that was also interesting to me. I know a lot of these antibiotics do have equal penetration into the joint, whether they're oral or IV, but these are pretty different from the international guidelines, not the drugs, but the fact that they're starting with oral medications rather than IV medications. Anyone who was practicing in the Gambia, I'd love if you can chime in whether your institution is following these guidelines, like whether you start with oral or whether you actually start with IV like the international guidelines recommend. Okay. Well, you can feel free to chime in the chat. I'm going to move on to Uganda's guidelines for septic arthritis. So they do not recommend giving empiric antibiotics in the outpatient setting or like at a small hospital where you can't do definitive care. They don't even mention like if the person's septic to give antibiotics. So I guess they kind of leave it up to provider judgment, but they basically just tell you to do symptomatic care. Don't move the limb around, try to splint it, which is the same as what the Gambian guidelines said, and then send them to somewhere that they actually can get definitive care. And once they do get to that setting, they recommend tailoring to the results of the gram stain and culture. So this matches the international guidelines where they're saying if it's gram positive, if gram stain, give cloxacillin. They're saying to give IV first. And then chloramphenicol is an alternative agent if you don't have cloxacillin or there's an allergy or something like that. They do say to do the IV antibiotics for 2 weeks, and if you're getting better, then switch to oral at that point. So they give more of a definitive timeline rather than guiding based on the patient's clinical improvement and their laboratory values. And then if you have an initial gram negative on gram stain, they're recommending ceftriaxone. They have a long IV therapy duration, 2 to 4 weeks, rather than switching to orals. So I am curious what people are doing in Uganda, if they're doing a full 2 to 4 week course of IV antibiotics before switching to oral medications. And then an alternative for ceftriaxone, if you have a gram negative organism, they're recommending ciprofloxacin, which does go along with the international guidelines that I was reading. In folks who have a negative stain and then you're worried because they have underlying sickle cell disease and salmonellas on your differential, they're saying to just go ahead and give both antibiotics. So something to cover for everything. And I would agree with that. And if you think it's gonococcal, then ceftriaxone, which also makes a lot of sense. All right, so now we're going to move on to osteomyelitis. These are, again, international guidelines. And so for osteomyelitis, sorry, I didn't mean to skip ahead. They are actually saying that Staph aureus needs to be the bug that you're covering against, and they really strongly recommend that you cover for MRSA if you have community prevalence of MRSA where you work. I am curious if people want to chime in either out loud or in the chat if they have community-acquired MRSA in their setting or not. I know we do very commonly here, but it's not super prevalent everywhere. I did ask around about it in the Gambia, and people seem to say that they don't have a lot of community-acquired MRSA yet, so I hope it stays that way. And then they're saying here that if the clinical presentation isn't suggestive of Staph aureus, or you think there's some other weird bug like Kingella going on, then you should be covering for that bug. And so the Gambian guidelines for osteomyelitis are suggesting that you give cloxacillin orally, chloramphenicol orally, or erythromycin orally. So again, all oral medications, no IV, which is pretty different from what I've seen here in my practice in the US. So I would love to hear if anyone is working in the Gambia, if you are typically giving IV antibiotics first, or if you're giving oral for osteomyelitis. There is a lot of data now to suggest that most antibiotics are equally penetrate bone, whether they're oral or IV. And so honestly, there might be a point in time when these guidelines, the international guidelines, are changing and recommend we start with oral and not IV unless someone's septic. But for now, the Gambian guidelines do say to start oral for osteo. And then if you have sickle cell disease, though, they are strongly recommending that you give IV agents because these people are at higher risk for bad outcomes, and that you probably cover for salmonella, which I would definitely agree with. The Ugandan guidelines, just like with septic arthritis, they're saying to splint, to mobilize the limb, which makes sense. If you move your limb around while you've got these horrible infections, maybe there's an increased risk. Well, first of all, for increased pain, but then also for mobilizing that infection to other places. Relieve pain, send them to somewhere that has definitive care. And then their empiric guidelines would be IV cloxacillin for 2 weeks, and then continuing oral for at least 4 weeks. So they're starting off with IV, which is what I see in my setting as well. Fatimata, thank you. We give IV for acute and then oral for 6 weeks. I think that's so interesting that the guidelines say oral. Do you want to chime in either out loud or in the chat as to why the Gambian guidelines say oral up front? Because it sounds like you guys are doing the same thing they're doing in Uganda and in my setting, which is starting with IV antibiotics for osteomyelitis.
So for the acute cases, we give IV antibiotics and we maintain them on oral medication when they're going home for 6 weeks. But when they come with chronic osteomyelitis, what we do is then we give the oral for 6 weeks. Yeah.
Interesting. Maybe we need to get talk to someone about those guidelines then, because it sounds like you guys are always starting with IV for the acute case.
Yeah, we give IV for acute when they come with acute osteomyelitis.
Awesome. Thank you so much for the clarification. I appreciate it.
You're welcome.
All right. And then Ugandan guidelines, just like international guidelines, is that you need to usually have surgery for osteomyelitis. So especially if there's an abscess, that's got to be debrided and drained. It needs to get out of there. And then even if there is no surrounding abscess, if someone's not getting better with 48 to 72 hours of antibiotics, they definitely need some sort of surgical intervention to debride that bone. And in the setting of chronic osteo, those really do need debridement surgically. They need to get scraped away so that that thing doesn't continue to rot the bone. So I wanted to do a couple discussion questions here that Dr. Najai had put together. What challenges have the attendees today faced with diagnosing and treating pediatric orthopedic infections? And it might be a combination of question 1 and 2. Have you had issues getting appropriate imaging? Have you had issues getting first-line antibiotics? What have been the biggest challenges in your setting with treating pediatric orthopedic infections? I know when I work at my community hospitals, we often do not have the ability to get an MRI. And so some of these people are going to have to get transferred. Oh, thank you, Dr. Deboda. Imaging facilities not readily available, especially MRI. Yeah, it seems like that's a pretty universal thing, is that MRI is pretty hard to get. And as we've said, osteomyelitis takes a while to show up on X-ray. It's a limited test. CT would be a next best thing, but it's also not even close to perfect. Point of care ultrasound can help, but it is not even like in the guidelines in terms of where it falls with its sensitivity and specificity. And then especially for septic arthritis, are most people able to access ultrasound at their facility to see if there's a joint effusion that they can tap? Or are people just clinically diagnosing and then going ahead and doing an arthrocentesis without ultrasound? Nick, would you mind just muting Caroline for me? Okay, Dr. Devotis said patients pay out of pocket, so some patients cannot afford both the imaging and antibiotics. That's a great consideration too, right? If your patient cannot afford to get an MRI in addition to the antibiotics, you might have to just resort to giving the antibiotics. Not ideal. How hard is it to get an arthrocentesis at your institution? I know that for a hip, typically emergency medicine physicians where I work don't do hip arthrocenteses. We usually defer to orthopedics and have them do that. But if it's another joint, if it's knee, if it's elbow, if it's wrist, hand, shoulder, I'm usually tapping that joint, which is kind of weird. And I don't know why we have that dichotomy. It's almost like a culture thing because tapping a hip is the same procedure and theoretically we could do that. Nick, I know you just moved to a new institution. Are emergency medicine physicians doing hip arthrocenteses or are they usually deferring to orthopedics where you work?
It's a good question. I'm not sure entirely what common cultures there because I haven't run into it yet. My impression is that it would not surprise me if I found out that other attendings were tapping hips without talking to ortho. Our orthopedics are very supportive, and so like the other day there was a reduction that slipped out again, and they reached out to ortho and they're like, "Hey, do you think you need to come do this, or like should we do it?" And they're like, "Oh, it needs to get re-reduced, but." If you want us, we're happy to come down, but you can do it again if you want. And so it wouldn't surprise me if somebody felt comfortable tapping the hip if they would. But I haven't seen it come up yet.
Okay. JD, I'm curious because you rotated at Children's Mercy, which is a big children's hospital. Did the emergency medicine physicians there do hip arthrocentesis on children, or did you see them deferring to orthopedics for that?
So I saw one patient get a hip arthrocentesis in the emergency department, but it was an Amish child who are notably very stoic in our area. Those families can't really, they pay out of pocket for everything as well. So they did not want to do any sort of sedation or pay for higher procedures. And the attending that day felt comfortable with ultrasound and identified it himself. So we tapped it that way. But that's the only time I've ever seen it from an emergency medicine physician.
Interesting. And just for context for our attendees today, the Amish are a religious sect in the United States that kind of lives separate from the rest of society. They kind of live like it's the 1800s and they don't believe in vaccinations and often they don't have health insurance. So that all those things change our decision making in terms of how we care for them because we have to talk about costs with them up front if they're paying out of pocket for their care, just like Dr. Debota mentioned in her population. And then unfortunately, they are at higher risk for scary infections with things like H flu and other stuff that we would normally be preventing with immunizations. Interesting, JD. Thank you for sharing that. It sounds like in Dr. Debota's setting, most physicians are not trained on arthrocentesis in general. I'm going to make sure that we get a video on how to do arthrocentesis uploaded to our platform, and I'll let you guys know when it's there. Certainly don't do it on your own without some instruction and training from an orthopedist and without kind of discussing with them that you'd like to learn how to do that in your setting if you're working in accident and emergency. But I think especially for less complicated joints like knees, we should really feel empowered to be able to tap that ourselves in the frontline setting, whether you're in primary care, in the outpatient setting, or if you're working in an accident and emergency unit, because it can help us rule out some bad stuff without having to necessarily transfer for a consultant if it turns out that the studies look totally normal. That being said, don't go tapping a joint if you don't have the ability to look at the fluid, right? So if you don't have a lab at the place where you work in order to do a gram stain, in order to do appropriate cultures, then you shouldn't be tapping there. The patient really needs to go where they can get definitive care. All right, so some take-home points today. Prioritizing your clinical assessment. So how does the patient look? If they are septic, then you should be more worried and we should be getting cultures. And I don't really care what their white count or ESR or CRP look like if the patient looks septic. But those things can help you with your decision-making for the patient where you're a little bit on the fence as to whether they have a serious bacterial infection. Early diagnosis for septic arthritis especially, but also for osteomyelitis are critical because these diseases can have long-term morbidity and mortality if untreated, right? So if you leave these things and they're not getting treated, these infections can spread elsewhere. And if these kids have infection in their joints and in their bones, they may have chronic growth problems and arthritis and stuff like that. Use whatever you have for available imaging first, and just remember there are limitations to all of these types of imaging. MRI is the best choice, but you don't always have that, so you have to work with what you've got. Ideally, cultures before antibiotics, and we're referring to both blood cultures and cultures of the infected joint or bone. If the patient is septic, then you can go ahead and give empiric antibiotics before you tap the joint, because it takes a while to get that joint tap in a lot of the places where we work. And then make sure that you are tailoring your treatment based on your institutional protocols, your national guidelines, and then based on whatever bug you think may be causing the infection. That is all we have for you guys today. I am going to put the link to our, what is it called? Survey. Our participation survey in the chat, so that you guys can provide us with feedback. And we use that feedback basically to help make these sessions better for you every time. We've taken the feedback that people have given from prior sessions and incorporated it. I know we didn't do any baseline multiple choice questions this time, and I'm sorry about that. Dr. Najai wasn't able to come at the last minute, so I had to do some quick preparation for this. But in the future, we will have some multiple choice questions at the beginning of each session, because that's something you guys have asked for, especially those of you in Uganda who are used to attending the echo sessions and like having that. But again, please fill out the survey. Nick and JD and I will stay on for a couple of minutes if you have any questions, and I want to thank all of you for being here. Hope to see you at future CMES Journal Club sessions, and I would encourage you to go do more reading and listening about osteomyelitis and septic arthritis. You can check out our CMES platform if you have a device at your institution, or do a little bit more homework online. And we will be sending out the slides, the video, and the summary via WhatsApp. Thanks again.